The goals of formal antimicrobial stewardship programs are to achieve optimal clinical outcomes related to antimicrobial use, minimize toxicities and other adverse events, reduce the cost of healthcare for infections, and limit the selection of antimicrobial resistance. The CDC has provided guidance regarding the essential components of a stewardship program. Each program should have a physician leader, preferably with training in infectious diseases and specifically antimicrobial stewardship, who is responsible for program outcomes. Each program must also identify a pharmacist leader who is responsible for working to improve antimicrobial use. To be effective, programs must have support within administration and should work closely with hospital programs with clear overlapping goals, such as the infection control program, whose goals include reduction of C. difficile infections. Other key stakeholders include the microbiology laboratory, the quality improvement department, and other frontline clinicians. ASP interventions are designed to measure and optimize antimicrobial use and minimize adverse events and resistance. The best strategies for the prevention and containment of antibiotic resistance is not definitively established due to a lack of clinical evidence. Most stewardship programs use multiple interventions simultaneously and are often in collaboration with key stakeholders, such as infection control programs, to minimize the spread of resistance. Programs should select interventions based on local antibiotic utilization patterns, available resources, and expertise. Effective ASP programs can be financially self-supporting and improve patient care. In the literature, these programs have shown decreased antibiotic use by up to 36% and annual savings up to $900,000. The emphasis of this module, again, will be on ASP interventions in the inpatient setting. Antibiotic oversight is the foundation of any stewardship program and should include one or both of the following strategies: pre-authorization or prospective audit and feedback. Pre-authorization requires clinician to obtain approval for select antimicrobials before they are prescribed. Prospective audit and feedback involves trained staff, usually ID pharmacists and/or physicians, who review antimicrobial orders after they are placed and provide verbal or written recommendations to the primary team. Both methods have shown decreased antibiotic use and reduced antibiotic resistance without negatively impacting patient care. First, looking at the advantages. Pre-authorization reduces initiation of unnecessary and inappropriate antimicrobials. It optimizes empiric choices and influences downstream use. It decreases antibiotic costs and can focus on those that are extremely high cost in certain institutions. Prospective audit and feedback, on the other hand, provides educational benefit to clinicians, does not interfere or delay first doses of antibiotics, allows for provider autonomy in empiric choices, and allows ASP members to address de-escalation and duration of therapy once there is more clinical data available. Logistically, for ASP programs, it also allows flexibility in timing and frequency of recommendations. Now let's compare the disadvantages between these strategies. Pre-authorization occurs in real time and is resource-intensive, often requiring extensive coverage through an approval pager. It focuses on empiric use rather than downstream use. Because first doses are not generally released without approval, there may be a perceived loss of prescriber autonomy, and this may inadvertently delay first doses. Prospective audit and feedback is typically labor-intensive due to more intense case reviews once more data is available. Often, identifying appropriate patients for intervention may itself require tailored computerized system builds, which are also time-intensive to build and validate. Other supplemental strategies include development of facility-specific clinical protocols, point-of-care interventions, such as automatic IV to PO conversions, dose optimization, and therapeutic drug monitoring. Prescriber-led review of antimicrobials, such as the antimicrobial timeout. Antimicrobial allergy assessment, for example, delabeling of penicillin allergies. Education of clinicians and patients. And other interventions that contribute to the reduction of C. difficile infections. Implementation of facility-specific clinical practice guidelines can lead to substantial changes in antibiotic use for infections commonly treated in hospitals. Most published studies of clinical practice guidelines have involved pneumonia, including community-acquired pneumonia, CAP, and hospital-acquired pneumonia in adults. Specific improvements in antibiotic use associated with implementation of facility-specific guidelines have included statistically significant increases in likelihood of adequate initial therapy, use of narrower spectrum antibiotic regimens, earlier switch from IV to PO therapy, and shorter duration of treatment. For those studies powered to detect differences in clinical outcomes, reductions in mortality, length of stay, adverse events, recurrence or readmission, and treatment costs have been demonstrated. Hospitalized patients receiving antimicrobial therapy are generally started on intravenous antibiotics. There are some antibiotics that have an extremely high bioavailability and can be converted to oral therapy once the patient meets certain criteria. Antibiotics with high bioavailability include fluoroquinolones, linezolid, metronidazole, clindamycin, and trimethoprim sulfamethoxazole. Antifungals with high bioavailability include fluconazole and voriconazole. Studies have shown that early conversions from IV to PO antibiotics can result in reduced length of hospital stay, reduced healthcare costs, reduced infections, and reduced morbidity. Programs can assist in creating guidelines and protocols for renal dosing, dialysis dosing, alternative dosing strategies of beta-lactams, and therapeutic drug monitoring. Example programs include vancomycin and aminoglycosides per pharmacy, which have been shown to reduce nephrotoxicity, improve time to therapeutic levels, and in some studies, improve clinical outcomes. Strategies to decentralize routine antibiotic review include self-stewardship, antibiotic timeouts with or without automatic stop orders, and prompting on checklists. Successful programs appear to require a methodology that includes persuasive or enforced prompting. Antibiotic stop orders, for example, have been best studied with vancomycin. One study reporting significantly decreased continuation, 11% versus 25% before and after implementation of a 3-day vancomycin stop order in situations without documented gram-positive infections. Strategies include educational meetings with didactic lectures and distribution of educational pamphlets and materials. Educational outreach should be done regularly to both refresh and update the learners regarding principles of antibiotic use and to reach new prescribers. Training programs should integrate antimicrobial stewardship program education in their core curriculum. Education alone, however, is a weak intervention and is best used in conjunction with other ASP interventions for sustained effects. Institutions may also target high-risk patients with invasive fungal infections. In designing interventions, programs should consider local fungal epidemiology and antifungal resistance rates. Some potential targets for programs include de-escalation of empiric anti-candidal coverage to fluconazole, as was discussed in the candidemia module. Programs can also assist in the optimization of antifungal dosing by therapeutic drug monitoring, or TDM. Serum drug monitoring may be considered to monitor for efficacy and/or toxicity, but it should be noted that recommendations are often based on limited data of associations between blood levels and response or toxicity, not prospectively controlled trials. TDM may be helpful in patients failing therapy, treatment of uncommon or in vitro less susceptible organisms, extensive or deep-seated disseminated disease, patients with questionable absorption or drug interactions, and can be used to monitor for adherence.
The need for setting up an antimicrobial stewardship program, or ASP for short, is clear from a clinical perspective. But how do you make a business case for the program to the hospital leadership? And what are some of the things you need to keep in mind when proposing a new program? We'll talk about some of these issues. Start by recognizing that the ASP proposal is going to compete with other projects for two things. One, resources to build an infrastructure, and two, attention of the clinicians who are being asked to do many other things. Now, both of these require buy-in from the senior leaders who are setting the priorities and are allocating resources. So what are some of the things you need to keep in mind as you work on your ASP proposal? Start by learning what the priorities are for the hospital or the system. A typical hospital will have 20 to 30, sometimes more, improvement initiatives in any given year, with 5 or so listed as strategic priorities. And these can be clinical, operational, or financial priorities. Learn what these initiatives and priorities are, and recognize that the stewardship program will compete with these for both resources and attention. And this should give you some important context as you shape your proposal. The second thing you should do is learn how decisions are made. The hospital leaders want to do the right thing, so help them understand what you're proposing in terms that allow comparisons across projects that are competing for their attention. And most senior leaders make decisions based on at least 4 things. 1, the importance and the relevance of the proposed program to the strategic priorities. The investment that's needed, and the investment could be in staff, it could be in IT resources. What the return on investment is, which could again be financial, operational, or clinical, or ideally all 3, and their confidence in the ability of the team to execute. Now, this is one of the intangibles, but it's an important factor that goes into their decision. The third recommendation is to make your ASP proposal crisp. I suggest framing it as a value improvement initiative. Frame how the program will improve quality and lower costs. That's the value proposition. Include goals and metrics that are clear and achievable over a short time horizon, not just 5 or 10-year plan, but what are you targeting to achieve in the first year, in the second year, and so on. Now, as you're setting goals, reducing emergence of drug-resistant organisms is certainly an important goal clinically, but it's hard to translate this goal or quantify it. Instead, list the antimicrobials that you'll be targeting, what their baseline use is, and what the target for improvement is. Now, one caveat, you should remind them that the goal is appropriate use, not just reduction in use of antimicrobials. Including baseline cost and a dollar opportunity will provide a clear reference as they look at the ROI. Citing benchmarks and best practices will make the case stronger for the resources you're asking for. Now, if these investments that you're asking for will not be fully offset by the direct cost savings, it's important to highlight the other tangible benefits, such as improvement in patient outcomes and patient experience from lower C. difficile rates. Next, list any regulatory or compliance standards, for example, the Joint Commission or the CDC, and any impact that the initiatives will have on value-based purchasing payments or on publicly reported measures. Keep in mind that C. difficile rates are part of the Medicare Hospital-Acquired Conditions, or HAC, penalty calculations. Show how you will coordinate with, or even better, how you will add to existing improvement efforts. For example, compliance with the sepsis bundle, which is a core measure, and improvement in sepsis survival rates by supporting timely and appropriate antibiotics and ensuring an antibiotic timeout. Now, if you can, highlight any prior accomplishments of the team and progress that may already be made, especially if you've had a pilot program. That can be really useful in making a case that the team is likely to execute on the program. The fourth component is implementation and monitoring. If the investment required is sizable, it's better to propose a phased implementation, which can help you get the resources in increments as the program achieves targets, perhaps year by year. And most hospital leaders will see this as a demonstration of a partnership rather than a quid pro quo transaction of resources. Now, it is important that once the resources are committed and the program is established, that you provide regular updates on progress using the metrics you had established for the program as part of your proposal. As the program develops, there's a good chance that you will have to go back for additional resources. And having an accountable, metric-based relationship will help the next conversation. Thank you, and good luck.
How do you identify where your stewardship program is doing well and where there are opportunities for improvement? And how can you tell what sort of impact your stewardship program efforts have made? Collecting and reporting stewardship metrics is not just a matter of good practice, but will soon be a requirement of government and regulatory bodies. We're going to focus on two questions in this section. The first is what your stewardship program should measure. While there are many important potential areas to measure to assess your stewardship program, there are two that are a focus of recent guidelines. Then we'll spend the rest of the time discussing the specifics of how to perform these measurements by working through examples. The world of antimicrobial stewardship has finally been noticed by key regulators of healthcare system quality, including the Joint Commission and the Centers for Medicare and Medicaid Services. These groups have recently promulgated guidelines for antimicrobial stewardship activities for participating institutions. These guidelines, along with recent ones from the Infectious Diseases Society of America, address issues of measurement and reporting in antimicrobial stewardship. The two common elements across these guidelines are recommendations to measure the aggregate use of antimicrobials and the patterns of antimicrobial resistance. In future years, these data elements may even become publicly reportable. So let's focus on these two metrics. The first step in measuring antimicrobial use is determining what you will actually be measuring. Most clinicians would consider use of antimicrobials to be administration of a drug to a patient. But it turns out that most studies that report antimicrobial use are actually measuring a different step in the antimicrobial use process, from as far removed as the drug being purchased by the pharmacy, through various steps of ordering and delivering the drugs, to steps that occur after the use has actually occurred, such as billing data. It's important to know what step in the process you are measuring, since the data may exist in different places depending on the step, and because comparisons are most valid when performed at the same step. After you decide the step and source of your data, you'll want to consider what numbers you actually want to measure. This depends, not surprisingly, on what you want to know. If you want to know how often patients are getting any or a particular antibiotic, you'll be interested in a point, which occurs at a particular time, such as at ICU admission, or period, for example, over the course of an admission, prevalence. If you're less interested in the start of antibiotics and more in their finish, you can examine the mean or median duration of antibiotics for all causes or for a particular infection. Obviously, both of these contribute to the total amount of antibiotic use, and so a commonly used metric is the incidence density rate of defined daily doses or days of therapy per 1,000 patient days. Adjusting for patient days allows comparisons between time periods and across institutions and services with different numbers of patients and different lengths of stay. There are two primary metrics for measuring aggregate antimicrobial use, which are meant to allow valid comparisons across institutions and over time. Historically, the defined daily dose methodology, which is endorsed by the World Health Organization, has been the most common metric reported in the literature. However, DDDs, as they are called, are very sensitive to a number of influences, including the mix of pediatric patients, patients with renal dysfunction, use of milligram per kilo dosing, and trends in the dosing of antibiotics. The end result can be substantial and unstable variability between the number of doses used and the DDD results. Days of therapy is an alternate metric that is less sensitive to these influences. It is the dose methodology endorsed as the standard metric by the CDC's Antimicrobial Utilization Module and will likely be the primary metric in the US going forward. Defined daily doses can be measured on a variety of data sources and involves summing the total grams of drug used during the period of interest and dividing by a number set by the World Health Organization representing an average or defined daily dose. Days of therapy involves summing the total number of days that a patient received any number of doses of a drug. Both are then adjusted for some measure of time at risk, such as patient days, bed days, admissions, etc. These numbers are then typically multiplied by 1,000 simply to avoid small fractions. This table is an example on the level of an individual patient of how the two measures, defined daily doses and days of therapy, are calculated. For DDDs, the total number of grams of drug is summed and divided by the defined daily dose, which is supposed to be the standard dose given. For days of therapy, you simply count the number of discrete days the drug was given on. Depending on the drug, the dose given, and the WHO's definition of a daily dose, sometimes the DDDs and DOTs give the same answer, as illustrated in this case by vancomycin and moxifloxacin. Sometimes they don't, as illustrated by ampicillin sulbactam and cefazolin. So while either can be a valid measure, they really shouldn't be compared to each other. Next, let's discuss measuring antimicrobial resistance. Now, at a particular institution, the infection control departments or microbiology may have assumed responsibility for aggregating and reporting antimicrobial resistance data. However, it's essential for the Antimicrobial Stewardship Program to understand how that data was gathered, filtered, and reported. As we'll see, decisions about what isolates to include can have substantial impacts on an institution's apparent level of antimicrobial resistance. So let's talk about what we're discussing when we talk about aggregate antimicrobial resistance, with a very simple example looking at the results of culture and susceptibility testing for 4 patients and a single drug. There are 2 primary ways to quantify this data in the aggregate. The first is by expressing it as a period prevalence, the percentage of resistant or susceptible isolates over a defined time period. This is most useful for clinicians selecting empiric therapy based on past patterns of susceptibility, as on an institutional antibiogram. Alternatively, resistance could be expressed as a rate, the number of resistant isolates divided by the number of admissions. In large data sets, this is typically multiplied by 1,000. This is most useful for surveillance as it captures the number of infections as well as the burden of resistance. Because period prevalence is most commonly used in the context of antimicrobial stewardship programs, we'll concentrate on that here. A key consideration in understanding the reporting of aggregate antimicrobial resistance is the variety of rules that may be applied to these reports before the end users see them. It is rare that reports of aggregate antimicrobial susceptibility simply reflect the sum total of all bacterial specimens tested by the microbiology laboratory. Whenever you're reviewing an aggregate antimicrobial susceptibility report, it's important to ask which rules were applied to the data. Common examples include inclusion of only isolates submitted from inpatient locations, which can leave the emergency department as a gray area for decision in terms of whether or not they should be included in an inpatient antibiogram. The exclusion of isolates taken for surveillance purposes only, for example, nasal swabs for MRSA colonization. The use of only the first isolate per patient per time period as for inclusion in the antibiogram, and we'll talk more about this later. And finally, the use of very specific location data like ICU-only isolates. To attempt to standardize the application of these various rules and reporting formats, the Clinical Laboratory Standards Institute has developed a set of recommendations for reporting of aggregate antimicrobial susceptibility data in antibiograms. For example, it's recommended that reports are aggregated on a yearly basis. More frequent reports are possible, but for meaningful conclusions, there should be a minimum number of isolates in that time period. Only routinely tested antibiotics should be included to avoid bias when only a subset of drugs are reported. There can be substantial differences in results based on whether the isolates represent inpatient, ICU, or outpatient isolates, and so the source of the isolates in an antibiogram should be clearly described. Similarly, in some cases, there may be value in reporting out specific infection sites, such as the urine, which should also be specified in the antibiogram. The report should reflect cultures taken for diagnostic purposes only and be quantified as percentage susceptible instead of percentage resistant. Finally, patients may contribute multiple isolates of the same organism over time. The recommendation is to include only the first isolate that each patient contributes of a particular organism over the time period under study. Let's take a further look at why this last point is important. Let's take a look at a small group of patient isolates collected over a 1-month time period. Consider all of these isolates to be of the same organism, maybe something like Pseudomonas. Some patients have multiple isolates of the organism over the time period. If the susceptibility results from all of the isolates were included, then we'd find that 50% of the isolates were susceptible. But some of the patients contribute multiple isolates, which can result in a biased number if the goal is to get the best idea of how to select empiric therapy for a new patient. Applying rules to exclude repeat isolates in a given time window, such as 7 days or 30 days, can give conflicting results depending on the window chosen. Thus, the CLSI's recommendation is to recommend including only the first isolate per patient per time period for aggregate reports meant to guide empiric therapy. And in this case, you can see a substantial difference from the susceptibility report compared to when all isolates are included. In summary, the place to start with antimicrobial stewardship metrics is in making sure you can collect and report 2 measures: aggregate antimicrobial use and aggregate antimicrobial susceptibility. In terms of the best methodologies for doing this, days of therapy is becoming preferred over defined daily doses for measuring aggregate antimicrobial use, and methods of reporting aggregate antimicrobial susceptibility should conform to guidelines put out by CLSI. Acquiring and manipulating this data can consume a substantial amount of time, so a key component of a successful stewardship program is the funding and personnel necessary to report out this information. In Part 2, we'll discuss how to put the data that you've gathered into context for actionable use. In part 2 of our discussion about measurement and metrics in antimicrobial stewardship, we're going to talk about how to put the data that you generate in context so that you can use it to take action. We're going to focus on the measures of days of therapy and antimicrobial susceptibility as a period prevalence. So if you haven't seen part 1, you might want to view it to familiarize yourself with how the data is generated. Let's talk about what we do with this data that we've gathered, including some of the challenges in separating the signal from the noise, as well as national initiatives that aim to make benchmarking much easier. Once you obtain your data, whatever it is, it's important to put it in context. After all, knowing you use X number of days of therapy per 1,000 patient days of an antibiotic isn't intrinsically meaningful. One level of comparison is to some absolute standard. What should that number be? In a number of quality improvement contexts, we can set an absolute standard goal. No central line associated infections or 100% hand hygiene compliance. Those standards may be high, but they represent a clear goal. However, for some measurements, there's not a reasonable absolute standard. We certainly don't want our antibiotic use to be 0, and currently there is no magic number that represents the correct amount of total antibiotic use. Thus, we may be forced to use other standards for comparison. One way is to use your own institution's prior performance as a reference standard. When doing so, you'll want to make sure there's adequate data to ensure that you're seeing a real effect, rather than just some random variation. That you use the best techniques to estimate the effects of any interventions that might have occurred over the time period. Another means of contextualizing the data is through comparison to other groups. These might be other hospitals, or their teams or services within an institution. For this comparison, challenges can include obtaining data from comparators and ensuring that a comparator really represents a good benchmark for your institution. Okay, so first let's talk about how to use your institution's own data to provide context for your antimicrobial stewardship. A particular emphasis are the common mistakes that can be made when analyzing this data longitudinally, mistakes that can lead to substantially overstating the effects of your program or wasting your efforts on problems that are just random variability. On first glance, this graph appears to be an example of stewardship metrics demonstrating the success of an antimicrobial stewardship program. Over an 8-month period, vancomycin use in adults as measured by days of therapy per 1,000 patient days seems to be definitively trending down. However, there are substantial variations in month-to-month antimicrobial use, such that what may seem to be patterns over a period even as long as 8 months are part of the background variability. Note as well the impact that the axis scale has on the perceived magnitude of the fluctuations. Tracking usage over longer time periods can account for seasonal and other fluctuations and reveal long-term trends that may indicate targets for stewardship intervention. Tracking stewardship metrics over longer time periods, as in the example here with meropenem susceptibility in Pseudomonas, can collapse some of that month-to-month noise and may give confidence that a trend that is apparent is actually real. However, it's important to remember that variability still exists that should be accounted for, especially when organisms that are less commonly isolated are being tracked. Applying confidence intervals or error bars to the data points can indicate the degree of uncertainty around estimates and reduce the likelihood of overstating trends, again, most helpfully when combined with a greater range of data points. For more common organisms, there's less uncertainty and significant trends and shifts over time can be detected with a greater degree of confidence that these are areas to definitively target. What about when an intervention is actually put into place? What's the best way to measure its effect? Here's an example of antimicrobial use data over a 3-year period in an institution, although the concepts apply to any data that can be measured at repeated intervals over time. Let's consider this data is being collected to evaluate the impact of an antimicrobial stewardship program, which is given 1 year to show its effect on utilization. We can ask what the best comparisons to perform on this data set might be. One might compare the use just before the program was implemented to the utilization at the end of the study period, as indicated by A. But in this case, it would give a misleading story that there was little effect of the program. Even worse would be comparison of the utilization immediately before to immediately after the initiation of the stewardship program. It's unlikely there would be enough time to see a true effect, and instead, the random variation might lead to the conclusion that the program increased utilization. Many studies would report the mean use in the period before the intervention and mean use during the intervention period, indicated by C. But this doesn't count for the underlying trend in utilization, which was clearly increasing before the intervention and which flattened out afterwards. A more accurate comparison would be to compare the observed trend in antimicrobial use after the intervention to the projected trend in utilization if the intervention had not occurred, noted by D. Although slightly more complicated statistically, this interrupted time series approach is recognized as the most valid way to analyze and present such data. There are a number of real-life examples of studies where comparing the mean value of a metric before and after an intervention gives an incomplete or even false interpretation. In this case, the effect of an infection control intervention seems to have clearly reversed an outbreak of ceftazidime-resistant Klebsiella. Yet, the mean rate of ceftaz-resistant Klebsiella wasn't statistically significantly different. Interrupted time series analysis, however, would indicate that both the immediate effect of the intervention, noted by the change in level, and longer-term effect of the intervention, noted by the change in slope, were positive. The opposite effect can also be seen. In this case, the mean number of doses of vancomycin per 1,000 patient days decreased after an intervention to restrict its use. But the utilization was clearly downtrending before the intervention. While associated with a modest immediate reduction in use, the longer-term trend after the intervention was actually an increase in the slope of vancomycin utilization. Our examples show that actionable data can be gleaned from looking at trends in antimicrobial stewardship metrics over time, but that a lot of data points and a long period of time are required to see an effect. Many institutions will want a more immediate snapshot of what areas they're performing well in and what areas are targets for improvement. For this, obtaining data from peer institutions can be invaluable, but fraught with its own potential for error. This figure reports the aggregate antimicrobial use in terms of days of therapy per 1,000 patient days across 70 university hospitals. Even though these are all academic medical centers, there is nearly a twofold variation in usage from the lowest to highest users. In order to properly benchmark your own institutional data to this data, we'd like to be able to isolate what component of the variability comes from potentially improvable practice patterns, and what is the result of different mixes of patients across these institutions. This figure illustrates the impact that patient mix can have on utilization. In this hypothetical, and somewhat extreme for illustration purposes, example, two hospitals, A and B, have different percentages of patients on medicine, psychiatry, and transplant services. Although each service has the same utilization rate per patient for each service, 5 days of therapy per 1,000 patient days for medicine, 1 for psych patients, and 10 for transplant patients, the total utilization at Institution A is much higher because their mix includes higher use patients. Thus, these hospitals have similar rates of modifiable antibiotic use, but much different overall usage rates. This graph illustrates the same principle. Here, instead of comparing entire hospitals, antibiotic usage among patients on particular services in each hospital is plotted. This allows institutions to see where they compare in treating similar groups of patients, removing the effect of different patient mixes. Obtaining and analyzing the data for peer benchmarking can be a significant challenge. However, the CDC has made a huge step forward with the Antimicrobial Use module of the National Healthcare Safety Network Surveillance Program. Institutions that electronically submit their antimicrobial use data through this platform contribute to statistical models that adjust for patient mix and other interinstitutional variables. These models compare the measured antimicrobial days in a facility to the predicted antimicrobial days to come up with a standardized antimicrobial administration ratio. This SAAR can be used as an indicator as to whether usage during that time period was above or below that which would be predicted for the institution based on its specific characteristics. Analysis for all antimicrobials as well as for specific groups of drugs and hospital locations are available. Ask your infection control and IT folks today about participating in the Antimicrobial Use and Resistance module. What follows is an example of how antimicrobial stewardship metrics might be used to identify a high-yield opportunity for stewardship intervention. It combines longitudinal analysis with analysis of peer benchmarking data. This is data from our institution as to the use of common antimicrobials and groups measured in days of therapy per 1,000 patient days, along with the mean values for a group of 9 comparator institutions. This is a more useful way to view the same data as differences from the comparator mean. In a number of cases, differences can be explained by substitution effects. For example, while UCSF uses far more piperacillin tazobactam than the average, it uses much less cefepime, such that there is little difference in anti-pseudomonal penicillins and cephalosporins as a group. We were surprised that the next biggest outlier was vancomycin, so we decided to look into it more. It turned out that UCSF, in red here, had the second highest usage in the group of hospitals, substantially more than institutions at the lower end. This effect wasn't readily explained away by substitution with alternative agents. Total anti-gram-positive use was still high, driven by vancomycin use. Perhaps we're seeing something that was actually improving. We had made efforts to monitor vancomycin use. But looking at the data longitudinally, it was clear that we had seen a steady increase in vancomycin over time, even as the mean usage at the peer group of hospitals, indicated by the dotted red line, was essentially flat. Perhaps the increased use of vancomycin was clinically justified, based on an increase in MRSA. It can be tricky to answer this question, since potentially the MRSA rate could be held down by administering vancomycin widely before cultures are drawn. But our surveillance data suggested that while MRSA had been previously increasing, during the period we were analyzing our usage data, it was actually flat. A useful bit of information was figuring out what was driving the increased number of days of therapy of vancomycin. We were able to separate out the mean duration of vancomycin that patients received, noted with the dotted dark line, from the number of new starts of vancomycin, noted by the red line. Over the time period, the mean duration of vancomycin among patients who received it actually went down, but the number of new starts increased substantially, such that 25% of all adult admissions for any indication were receiving vancomycin during their hospitalization. There's clearly lots of vancomycin use in the hospital, and it can be a challenge to know whether to implement a hospital-wide intervention or a targeted intervention. So we wanted to see whether or not there was a substantial difference by service in this increased utilization of vancomycin. We had anticipated that the bone marrow transplant unit would be a large user based on the inclusion of vancomycin into the febrile neutropenia pathway, but were surprised to identify the General Medicine Service not only as a high-volume user, but one substantially above our peer hospital mean. This analysis allowed us to identify vancomycin as a real outlier in terms of utilization and to target a specific service for initial intervention. We've made some changes and we'll be analyzing the effect, when, of course, we've gathered enough longitudinal data points. So in summary, key metrics for antimicrobial stewardship have lots of noise obscuring the signal, so you'll need to gather lots of data points and estimate the uncertainty. There's a best way to measure the effect of a stewardship intervention. Graphs make the visual case, and interrupted time series analysis makes the statistical case. Benchmarking to peers has availability and apples-to-apples comparison problems, but the development of the CDC national database is a significant step forward. Finally, I hope our example showed that combining longitudinal and benchmark analysis can be very powerful. I hope this has been a useful module for you. Happy stewarding!
Hello and welcome to this module entitled Incorporating Clinical Decision Support Systems into Antibiotic Stewardship. A good first step in understanding this topic is to define what a clinical decision support system is or does. A clinical decision support system, by definition, matches patient information to a clinical knowledge base and generates patient-specific recommendations at appropriate times during the course of clinical treatment. These systems combine individual patient data, population trends, and evidence-based medicine into their informatics infrastructure to produce meaningful, actionable alerts. In addition, they have the ability to collate data on interventions, measure drug utilization, improve the safe use of medications, and quantify cost savings. The key word in the definition of a clinical decision support system is recommendation. It is not designed to replace the decision of a clinician, but rather to help identify opportunities and to add efficiency to the intervention process. There are two general categories of clinical decision support systems: those that are integrated into an electronic health record system, or EHR, and third-party commercial systems. The main difference between the two is whether or not the user has to go into a separate system to view the alerts. In an EHR-based system, the data and technology needed to generate the alerts are embedded within a single system. Not every EHR has the ability to generate actionable clinical alerts. The majority of EHR systems were not originally designed for this purpose. However, over time, this functionality is being embedded as newer versions come into the market. One of the key advantages of an EHR-based clinical decision support system is that it has the ability to prospectively influence antibiotic use at the point of order entry in real time and can be expanded easily into other areas of care, such as the ambulatory clinic setting. Third-party commercial systems are typically standalone, running in parallel with the EHR. Therefore, the user must go into a separate system to view the alerts and take action. Because these products have been in the market longer, they generally tend to have more functionality and pre-built rules within the system. However, unlike EHR-based tools, these systems do not have the capability to prospectively influence antibiotic use at the time of order entry. With a commercial system, the actionable alerts may be more retrospective in nature. This chart provides a comprehensive listing of the third-party commercial systems that were available at the time of this recording. The majority of these products have both antibiotic stewardship capabilities as well as technology to support infection prevention activities. In addition, many of them now have the capability to submit antibiotic utilization data electronically into the Antibiotic Use and Resistance Module, or AUR. The AUR module is part of the Center for Disease Control's National Healthcare Safety Network, which is also known as NHSN. If we go back to the mid to late 1990s, there were no commercial antibiotic clinical decision support systems that were available in the marketplace, nor was this functionality embedded into EHRs. The process of connecting laboratory, pharmacy, patient demographics, and clinical parameters was very fragmented. Although many hospitals had computers that contained some health information, paper charts were the primary repository for most information about the patient. Therefore, the process of identifying patients for antibiotic clinical interventions was very manual and time-consuming, which limited the number of patients that clinicians or groups of clinicians could review at one time. In the modern age, there was a significant increase in the amount of data available in a standardized electronic format, resulting in the development of clinical decision support technology. The graphic on this slide provides a schematic of how the information flows into the clinical decision support tool. For a third-party system, data streams feed into the software from different informatic sources, such as pharmacy orders, medical records, admission, discharge, and patient transfer information, and billing data. For an EHR-based product, most of the information already is contained within the main system. Regardless, once the data is integrated, clinical decision rules can be applied to generate alerts. Now large numbers of patients can be reviewed, and the frequency in which these interventions can be applied goes up substantially. Now that we have reviewed the technical aspects of these products, let's discuss the benefits of using an electronic system to help identify antibiotic stewardship opportunities. One of the main advantages of using technology to identify antibiotic stewardship opportunities is efficiency. An early study published in the New England Journal of Medicine evaluated the impact of a newly developed electronic clinical decision support tool on antibiotic-related interventions in an ICU. The investigators did a time and motion study to look at the average duration of time that it took to complete an intervention. They found that when an infectious diseases specialist had to manually review charts before making the intervention, that it took an average of 14 minutes. The computerized clinical tool was able to complete the same action in only 3.5 seconds when the process was automated. Cost savings has been documented with the use of these systems. These costs may equate to dollars that go directly to the bottom line, or what we call hard costs. An example of this would be a reduction in antibiotic spend or utilization, or a reduction in the length of stay. In some cases, the cost savings measured may be soft costs, such as reduction in personnel time or decrease in adverse events. These types of costs don't necessarily hit the budgetary bottom line, but they do have an impact on the quality and safety of care. Being able to measure the savings from these systems is important, as there is an associated purchase and implementation cost with these systems. So the measurement and reporting of costs may offset the financial investment that has to be made. This table provides a listing of common antibiotic stewardship alerts that are typically included in these different systems. A common alert that is generated is the organism-drug mismatch, which is also referred to as a bug-drug mismatch. For example, an actionable alert may be generated for a patient that has a positive culture for an organism, but that organism is reported as resistant to the patient's active antibiotic therapy. These systems can be very helpful in automating key elements of a successful stewardship program, including identifying patients for IV to oral conversion, identifying the need for an antibiotic timeout, flagging duplicate therapy, identifying patients who need to have their dose adjusted due to organ dysfunction, or flagging patients who are receiving an antibiotic but there is no indication for use documented in the medical record. Finally, customized rules can be built in these systems so that alerts are generated in patients receiving restricted antibiotics or have a positive culture for a healthcare-associated infection or a multi-drug resistant organism. In addition to infectious diseases-related alerts, these systems typically have the ability to generate other medication alerts as well. For example, alerts can be built in the clinical decision support system to identify patients with congestive heart failure who do not have an active order for an ACE inhibitor, or a patient who is receiving warfarin but may have a high INR. These systems can also help supplement the organization's medication safety program. For example, a daily report or active listing can be developed that will contain the names of all patients that have received diphenhydramine or naloxone within the last 24 hours. A pharmacist reviews the report and then conducts a follow-up investigation to determine if the patient had an allergic reaction or opioid overdose, as evidenced by the diphenhydramine or naloxone respectively. Almost every system has the capability to generate an antibiogram on demand. This is extremely helpful because it allows the users quite a bit of flexibility and allows them to customize the information based on dates or the organisms that are included. Many of these systems allow the user to track their interventions so that when the alert is received and an action is taken, it can be documented. This information can be aggregated and analyzed and presented to key stakeholders along with the savings achieved from these interventions. With the increasing emphasis on costs and cost effectiveness in healthcare, this savings quantification can be very valuable. However, it is important to be able to delineate between hard and soft cost savings. Other functionality within a tool such as this includes tracking antibiotic utilization. Common ways that these systems track antibiotic utilization include defined daily dose per 1,000 patient days, days of therapy per 1,000 patient days, or days of therapy per 1,000 patient days present. A small number of systems can also provide benchmarking data, although this is typically facilitated through a separate manual request from the company as opposed to an on-demand function. Finally, newer technology embedded in these systems is allowing for predictive modeling and personalized antibiotic therapy. In predictive modeling, the system takes into account all clinically available information and tries to predict what infection may be present, along with the likely organisms and their antibiotic susceptibilities based on antibiotic resistance trends at the facility. For personalized antibiotic therapy, the software will take the prescriber through a list of questions to help confirm diagnosis and then will generate a treatment recommendation that is specific to that patient and is based not only on population resistance trends, but also on information from that individual patient's medical record, including previous hospital stays. There are several challenges to consider when evaluating the best system that will meet the institution and clinicians' needs. Both EHR-based and third-party commercial systems require some type of IT personnel involvement. What must be determined is how many people will be needed to be dedicated to the onboarding and maintenance of the product, which can vary from system to system. Additional investment may be required if the technology is to be used with smartphones or other mobile technology. A big consideration with any of these systems is the ease of use. If a clinical decision support system is more intuitive and requires relatively few clicks of a mouse, then you may see easier or faster adaptation of technology, especially in today's environment where there is always demand on clinicians' time. If it requires multiple clicks of a mouse or several screens to scroll through in order to find the information, this makes the system less likely to be used. From a financial perspective, there can be two cost categories. The first is what we call out-of-the-box costs, which are the costs associated to get the basic system up and running. However, there may be more fees charged on top of the initial investment in order to access additional functionality or capabilities that do not come as a standard feature. For example, some clinical decision support systems have the capability to do keyword searches in radiology or surgery reports, but this is not included in the basic model and additional investment is required. Another example might be additional fees associated with improving mobile user experience or for supplemental training that is needed from the company when new staff members are onboarded. Although these systems have many pre-built clinical rules, additional time may be needed by physicians, pharmacists, infection preventionists, and others to add customized rules. This can be challenging because frontline clinicians have to be removed from their patient care activities in order to build and refine actionable alerts. Finally, there needs to be an infrastructure in place whereby dedicated personnel are available to act upon alerts in a timely manner. If clinicians are not in place to quickly review the opportunities that have been identified, then any type of antibiotic clinical decision support system will be of little value. So in conclusion, antimicrobial clinical decision support systems may be either EHR-based or part of a third-party commercial system. Many of these systems have both infection prevention as well as an antibiotic stewardship component. Hopefully it has been demonstrated in this presentation that there are pros and cons to each of the systems that are in the healthcare marketplace, but ultimately this medical artificial intelligence can save time and improve patient care. Thank you.
The microbiology laboratory plays two major roles in antibiotic stewardship program. The first role is to provide pathogen detection and identification from the clinical specimens. This facilitates species-specific antibiotic therapy, which in some cases is all that is needed to provide optimal therapy. This also allows discontinuation of unnecessary antibiotic therapy, which is not too uncommon. The second role of clinical microbiology laboratory is to provide antibiotic susceptibility testing, which facilitates strain-specific antibiotic therapy, leading to de-escalation of broad-spectrum antibiotics. The role of clinical microbiology laboratory and antibiotic stewardship is illustrated in this slide for the diagnosis of bacteremia. Here we have a septic patient that is being empirically treated with vancomycin to cover gram-positive organisms. And the goal is to detect and identify the pathogen, which in this case is methicillin-sensitive Staph aureus, and de-escalate therapy to a beta-lactam antibiotic. Here is how it is currently done in many laboratories. On day -1, blood culture is obtained. On day 0, positive blood culture is detected. The same day, gram stain shows gram-positive cocci clusters, which is suggestive of staph. Typically a day later, by biochemical testing, it is identified as Staph aureus, and on day 2 or 3, the antibiotic susceptibility assays identify it as methicillin-sensitive Staph aureus. The critical thing for the management of this patient is to de-escalate therapy from vancomycin to a penicillinase-resistant penicillin, such as nafthacillin, because beta-lactams have been shown to be superior to vancomycin in patients with invasive methicillin-sensitive Staph aureus infection. The microbiology laboratory uses a variety of conventional and non-conventional methods to guide antimicrobial therapy. The gram stain, one of the oldest tools available, can still quickly tell us if the pathogen is more likely to be strep, staph, or Neisseria. The microbiological culture for bacteria and fungi, which is a gold standard for microbial detection, can also, in a matter of 1 to 2 days, detect non-fastidious pathogens. And conventional automated systems can be used to perform identification and antimicrobial susceptibility testing for bacteria and yeast. In the past decade, clinical microbiology laboratory has been revolutionized by molecular methods which allow pathogen detection, identification, and even antimicrobial susceptibility testing, all in minutes to hours. For example, antigen tests with lateral flow assay, such as the cryptococcal antigen test and Clostridium difficile rapid membrane enzyme immunoassay, allow rapid detection of these pathogens in blood and stool. Nucleic acid amplification tests, such as on-demand PCR or batch PCR tests, are allowing rapid and accurate detection of all kinds of pathogens. In several instances, they can also simultaneously provide genotypic antibiotic susceptibility results. We now also have a new tool called MALDI-TOF, or Matrix-Assisted Laser Desorption Ionization Time of Flight mass spectrometry, for unbiased identification of bacterial and fungal pathogens growing in culture in just a few minutes. Even when culture and other tests are negative but signs of infection are present, we can use an unbiased nucleic acid amplification test to identify the pathogen. In these cases, broad-range PCR combined with amplicon sequencing is used to provide pathogen detection and identification. Going back to our example of bacteremia, where conventional methods allow de-escalation of therapy on day 2 or 3, with molecular methods, positive blood cultures can be identified in real time, and in the case of staph and enterococcus, also provide information on methicillin and vancomycin susceptibility. All of this is expected to provide same-day de-escalation of therapy. In fact, this is what we and others have found when MEK-A PCR for detection of methicillin-resistant staph is provided on positive blood cultures. Just by reporting methicillin result at the same time as identification result, we could reduce the time to vancomycin replacement and reduce vancomycin therapy and shorten time to patient discharge. For resistance mechanisms that cannot be detected easily with molecular methods, we can expect in the near future to see emergence of phenotypic antibiotic susceptibility testing methods that can provide same-day results, thus making early de-escalation possible for all drug-bug combinations. No matter what method the lab is using, the lab should only test and report selective antibiotics in order to improve targeted antimicrobial use. The decision on which antibiotics to test and report is based on recommendations by Clinical and Laboratory Standards Institute and consensus guidelines, local antibiotic stewardship program, drugs available on hospital formulary, and drugs and methods available for testing. Given that it takes time to perform antibiotic susceptibility testing, the clinical microbiology laboratory also plays a critical role in periodic development of antibiograms to guide empiric therapy until patient-specific results become available. Cumulative antibiograms should provide analysis of a large number of unique isolates and should be tailored for inpatient, outpatient, emergency department, intensive care unit, and other units. Here's an example of an antibiogram for gram-negative rods for Stanford Healthcare. It shows the method used, number of isolates tested per species, the percent susceptibility for each antibiotic, and limitation of results. In conclusion, the microbiology laboratory plays an important role in antimicrobial therapy of patients with infectious diseases. However, the practitioners play a critical role in empowering the laboratory to make a diagnosis. The practitioner must order the right test in order for the lab to detect the pathogen. The practitioner must also collect the right specimen in order for the pathogen to be detected, or otherwise a laboratory may never detect that insulting pathogen, and the antibiotic susceptibility results provided may not be relevant. Thank you. This concludes this session.
Each year, 2 million Americans are infected with an antibiotic-resistant infection, and for 23,000 Americans each year, that infection will be fatal. These infections, which include methicillin-resistant Staphylococcus aureus, extended-spectrum beta-lactamase producing for gram-negative infections, and carbapenem-resistant Enterobacteriaceae, strike both adults and children. For ESPL and CRE in particular, the group led by LaTanya Logan published data demonstrating a dramatic increase in infections observed in children since 2005-2006. Studies suggest that between 33% and 60% of children will receive at least one antibiotic while hospitalized. Studies have also shown that the biggest increase in antibiotic use is among our broad-spectrum antibiotics. For example, linezolid's use has increased over 200%. Furthermore, large variability in total use occurs when comparing freestanding children's hospitals, even when controlling for many factors associated with the severity of illness. The use in these hospitals range from 38 to 72 children receiving an antibiotic per 100 discharges. The majority of antibiotics, however, are used in the outpatient setting, with an estimated 49 million antibiotic prescriptions occurring in this setting in pediatrics. While antibiotics are important therapeutic agents, their use is often inappropriate. Among a group of 4 neonatal intensive care units, 806 of the 3,334 days of antibiotic, or 24% of the antibiotic days, were inappropriate. This resulted in 35% of these infants receiving inappropriate antibiotic use. These inappropriate uses included using too broad of therapy when a narrower agent was available, treating colonization, and not stopping antibiotics when appropriate. A more recent study performed at a children's hospital observed that 11% of vancomycin use and 6% of cefepime use were inappropriate. The surgical services were the most likely groups to inappropriately use these antibiotics. lack of de-escalation, or discontinuing was the most common reason to be inappropriate. Antimicrobial stewardship programs, like the ones at the Children's Hospital of Philadelphia, improve the use of antibiotics in children's hospitals through the core strategies of pre-authorization and/or prospective audit with feedback. CHOP uses pre-authorization for most antibiotics, including vancomycin, meropenem, ceftriaxone, and many more. 20% of their interventions were targeting a known pathogen, and 18% were for an ID consult. They had a high compliance rate with these recommendations of up to 89%. The financial impact was a drug acquisition savings of $150,000. Importantly, their program led to better care, and the cost savings involved with making sure a child was dosed appropriately in the treatment of meningitis was not even determined. Prospective audit with feedback has also been a successful strategy in improving antibiotic use in children's hospitals. DuPont Children's Hospital in Wilmington, Delaware, demonstrated a 21% decrease in doses of antibiotics with no changes to antibiotic resistance over the study period. At Children's Mercy Hospital in Kansas City, Missouri, a prospective audit with feedback program demonstrated an average monthly decrease in days of therapy per 1,000 patient days of 17% after the implementation of the program. Furthermore, the clinicians impacted by this program felt the program provided knowledge on appropriate antibiotic prescribing, as well as improved the quality of care. Furthermore, the clinicians impacted by this program felt the program provided knowledge on appropriate antibiotic prescribing, as well as improved the overall quality of care. Finally, a new study from Children's Hospital of Colorado has showed the impact of a prospective audit with feedback program that involves daily rounding with all inpatient teams prescribing antibiotics. This method is termed handshake stewardship. In this model, the ASP team reviews all new antibiotic starts and then does a daily rounding process where they meet with all medical and surgical teams to provide recommendations and to be available for questions. This program observed an overall decrease in antimicrobial use of 10% and specifically observed a 22% and 25% decrease in meropenem and vancomycin use, respectively. Pediatric-specific clinical guidelines have been an effective strategy in improving the use of antibiotics in children. In a study performed by Dr. Ross Newman and colleagues from Children's Mercy Hospital in Kansas City, after the implementation of a community-acquired pneumonia clinical practice guideline, the use of ampicillin for hospitalized children with uncomplicated community-acquired pneumonia increased to over 60% of children receiving ampicillin after the implementation of the guideline. Furthermore, the use of amoxicillin also increased to over 90% of patients discharged receiving this narrow-spectrum antibiotic. Guidelines or care process models have also been effective in the treatment of the febrile infants in the first 90 days of life. Dr. Carrie Byington and colleagues demonstrated that after the implementation of their care process model, that infants were more likely to receive the appropriate antibiotics and to have the antibiotics discontinued at 36 hours. Additionally, patients considered low risk were less likely to receive antibiotics. Finally, the total length of stay was decreased significantly without an increase in adverse events. Similar to adult ASPs, certain features should be in place to develop an effective pediatric ASP. Importantly, financial support for pharmacists and physicians is highly recommended. Adam Hirsch and colleagues demonstrated that among a group of children's hospitals, those hospitals that provided financial support for these core providers saw the greatest decrease in antimicrobial use. The neonatal intensive care unit is a unique area for pediatric ASPs. Currently, the Vermont-Oxford Network is conducting a quality improvement collaborative to improve the use of antibiotics in NICUs. Areas that hospitals have focused improving antibiotic use are early onset sepsis, necrotizing enterocolitis, and empiric treatment of late onset sepsis. For early onset sepsis, in infants 34 weeks and older, a validated risk assessment tool has been used to help clinicians know when it is safe to not prescribe antibiotics. This risk assessment tool uses the following factors: highest maternal antepartum temperature, gestational age, length of time a mother's membranes were ruptured, group B streptococcal carriage status, and type of intrapartum antibiotics given. This data gives the estimated probability of culture-confirmed sepsis as risk per 1,000 live births. Additionally, by taking into account the clinical presentation, whether they are well, it's equivocal, or clinically sick, the provider can reliably determine if an antibiotic is needed. This tool has reliably determined 350 confirmed early onset sepsis among 608,014 live births. The author suggests the implementation of this tool could reduce the use of antibiotics in up to 240,000 U.S. newborns each year. Other areas clinicians have been successful in improving antibiotic use in the NICU include standardizing the treatment recommendations involved with neonates with NEC. This would include basing the use of anti-anaerobic antibiotics on whether perforation is present, and to only continue vancomycin when an ampicillin-resistant enterococcus has been cultured. Additionally, establishing areas of agreement of the duration of therapies for each Bell stage can be beneficial. Finally, the empiric treatment of late-onset sepsis can be done avoiding the use of vancomycin unless specific risk factors are present. Data has shown that the use of oxacillin or nafcillin has not been associated with worse outcomes, even in patients that are bacteremic with coagulase-negative staphylococcus. Outpatient parenteral antimicrobial therapy is an important area for ASPs to intervene. A study from a freestanding children's hospital observed that among OPAT episodes not having infectious diseases or ASP involvement, that up to 78% would have at least one recommendation. These recommendations include appropriate lab monitoring, dose and drug change, and reduction in treatment duration. Finally, up to 40% likely did not even need the OPAT therapy. A significant cost savings from this study was up to $4,000 per OPAT episode likely will occur from both the improved safety of the use of OPAT and the cost avoidance from eliminating its use. Finally, improving the use of antibiotics in the outpatient setting is paramount. Jeff Gerber published one of the initial seminal papers in the Journal of the American Medical Association in 2013. He performed a cluster randomized trial of outpatient practices in the suburban Philadelphia area. He divided the clinics into education only versus education plus audit and feedback. The audit and feedback group received quarterly antibiotic prescribing data on their use of broad-spectrum antibiotics for acute otitis media, sinusitis, community-acquired pneumonia, and group A streptococcal pharyngitis. They observed a 12.5% reduction in broad-spectrum antibiotic prescribing for intervention practices versus only a 5.8% for control practices. For community-acquired pneumonia and sinusitis, the difference in intervention versus control were 12 and 20% respectively. While these were impressive improvements in antibiotic use, when the quarterly reports were removed, the broad-spectrum antibiotic use increased back to baseline. Additional work is needed to find the factors and strategies in the outpatient setting to improve antibiotic prescribing for children. So, in summary, antibiotics are frequently used in children. Strategies in both the inpatient and outpatient setting have been successful in improving antibiotic use. More work is needed to assure that antimicrobial stewardship programs are implemented in all hospitals and that children are included in the work of ASPs in all settings.
Outpatient parenteral antibiotic therapy, OPAT, has become a standard of care in the United States as well as some other countries, especially in Europe. The potential benefits of OPAT include avoidance of inpatient admission or shortened inpatient stay, both of which reduce patient exposure to nosocomial pathogens while reducing costs and enhancing patient comfort by allowing them to reside outside the hospital. Safe and effective OPAT requires oversight by the Antimicrobial Stewardship Program, given its complexities. At a minimum, all patients who are potential OPAT candidates should undergo infectious disease consultation and/or stewardship program review, and should be carefully followed by them for the duration of OPAT. While a number of criteria for appropriateness of OPAT can be used, the basic issue is this. If the only reason the patient requires inpatient status is antimicrobial therapy, they probably should not be an inpatient, assuming, of course, that there is a safe environment for outpatient therapy. More precisely, the following are among the questions that must be addressed in deciding whether a patient is suitable for OPAT. Does the patient in fact require antibiotic therapy? Is the patient's status sufficiently stable to allow discharge to an outpatient setting? Does the patient require continued administration of an antibiotic by the intravenous route, or can treatment be completed with orally administered antibiotics? Is there an antibiotic effective in the treatment of the infection that is suitable, for instance, has adequate stability for outpatient administration? Is the patient, and if relevant, the patient's caregiver, capable of dealing with the demands of OPAT? This might include the understanding the elements of administration in the home, availability of transportation to an infusion center, and the like. And finally, is OPAT financially feasible for the patient? For the patient who is deemed by consultation to be an OPAT candidate, the consultant and/or stewardship team should determine the following. What is the appropriate vascular access device? In general, if therapy is to be administered in the outpatient setting for 7 days or fewer, a peripheral IV may be used, and it only requires changing rather when clinically indicated. Alternatively, a midline catheter can be used, and perhaps most popularly, a PICC line is used, and this is recommended if greater than 15 days of therapy is to be administered or the antibiotic is likely to cause phlebitis. It's also recommended that this be avoided in patients with advanced chronic kidney disease to preserve vessels for subsequent AV fistula formation. A third alternative is a cuffed central catheter or a tunneled small bore catheter or an implanted port. The appropriate antibiotic or antibiotics and appropriate dose and infusion duration, taking into account pharmacokinetics and pharmacodynamics, must be determined. There must be avoidance of drug-drug interactions, and finally, there must be a plan for the duration of therapy. OPAT may be avoided in some patients who are not candidates for oral antibiotic administration by giving agents with extraordinarily long serum half-lives, such as dalbavancin or iridavancin, at the time of discharge. In the United States, these drugs, as of April of 2017, have received FDA approval only for the treatment of adults with acute bacterial skin and skin structure infections due to susceptible organisms such as Streptococcus pyogenes and Staphylococcus aureus, including MRSA. However, their acquisition costs are quite high, and this presents a dilemma to hospitals, inpatient pharmacies, because they shift the cost of antibiotics for the drug from the outpatient to the inpatient pharmacy. Monitoring of the patient receiving OPAT requires regular face-to-face visits, as well as so-called virtual visits, and includes evaluation of the response to therapy, evaluating opportunities to convert from parenteral to oral antibiotic administration, safety evaluation including recognition of drug toxicity, drug-drug interactions, evaluation for complications of vascular access devices, and the like, recognition of secondary infections, including those due to Clostridium difficile, and the decision to discontinue therapy when maximum benefit has been reached. Laboratory evaluation must be performed at least weekly with individual tests determined by the antibiotic or antibiotics being administered, and testing must be carefully tracked by the stewardship program. The aim of the laboratory testings include monitoring of response to therapy, the recognition of toxicity, as for instance, eosinophilia, determination of cytopenias, kidney injury, or myositis, and therapeutic drug monitoring when indicated. Often overlooked but necessary is continual monitoring of OPAT safety and efficacy for the purposes of quality improvement. The program should record and continually evaluate outcomes, including resolution of infection, adverse events, as well as the number of and reasons for readmission. These should be recorded and continually evaluated.